morning. I'm Larry Harrison. I'm the Chief of Surgical Oncology for Atlantic Health System. Dr. Whitman asked me to speak about, gave me the title, Melanoma Surgery for Recurrence, a chance to cut is a chance to cure. I thought that had quite the surgical bravado to it, and I thought maybe 10 years ago this would have been a great title, but I think today we're nicer folks, we're cuddlier. So I'm changing the title a little bit, a little wordier. Surgery is an appropriate treatment option for metastatic melanoma in the age of effective biologic agents. It doesn't have the same impact as that other one, but I think it's probably more appropriate. So when patients present with melanoma, and Eric presented a slide very similar to this, the vast majority of patients present with just local disease. And just with a simple excision, those patients are cured. A smaller percent, about 9%, will have disease in the lymph nodes, and Dr. Bickenbach spoke about that today. And then a very small percentage of patients will present with metastatic disease. And so the question is, why are you spending a half hour of your time on a Saturday morning just listening to a talk about metastatic melanoma? So why is it important? Well, it's important because if you look at the estimated new cases in 2018, it's over 90,000 patients. And that number is only going to increase over time. And for those of us that are mathematically challenged, if we just say take 2% as just a number, you take 2% of 90,000, it's 1,800 patients that you may affect with metastatic disease. So it is an important topic, despite the fact that it is a relatively small percentage. So as surgical oncologists, we often treat patients with metastatic disease, and so this is an important slide because these, for us, are the indications for surgical resection for metastasis regardless of where they're coming from or where they're going. First is when we use the term oligometastatic means small numbers of tumors, 1, 2, perhaps 3. It is always better to have a time difference between when the tumor first came to when it became metastatic. The surgery itself has to offer minimal morbidity and maximal benefit, risk-benefit ratio. The patient has to be a good operative candidate. The primary tumor, where the tumor started, has to be controlled or be controllable. Everything needs to be resected, can't leave anything behind. And finally, and most importantly, especially for this talk, no other means of effective treatment. This is our laundry list that we go through when we evaluate patients to whether we're going to resect metastatic disease. So this is a truism across the board. And there are data supporting the role of surgery for metastatic disease from a variety of tumor types, lung cancer, colon cancer, to any of these sites. The liver, lung, brain, the adrenal gland, pancreas even, and the GI tract. As a surgical oncologist, Dr. Bickenbach, myself, Dr. Whitman, we are what I consider the numerator doctors. And what I mean by that is if you take 100 patients who have a clinical problem, we know in general 95, 98% of the time those patients will have a certain clinical course. A very small percentage will also sort of have that unique biology that may respond to what we do. And it's our responsibility to identify which patients will have an effect from surgery. Now, when does surgery play a role for melanoma? And you've heard a little bit about this today. If you have just local disease, just a simple excision, plus minus sentinel lymph node is appropriate, and that's really 85% of the time appropriate. We heard from Dr. Bickenbach about the management of lymph nodes, what we do with sentinel lymph nodes, what do we do with clinically positive lymph nodes we didn't talk about, but most of the time that's to remove those. If it's in between the lymph nodes and metastatic disease, we call it in-transit disease. We may use surgery, we may not. And then finally, the topic this morning in terms of metastatic disease is what do we do? So you've heard a lot about this magic number 2011. So as of 2011, there was really no medical therapy that was shown to improve the long-term survival in melanoma. And surgery, by default, became the only option for that oligometastatic disease, the small numbers of tumor metastasis. A large percentage of patients with melanoma who have resectable metastasis when they first present. That number, 50%, is high, but it is a significant number. However, complete resection offers a survival of about 18 months and a 5-year survivorship of about 20%. And those numbers are before the era of effective biologic agents. Now, as of 2011, obviously there's been a host of drugs that have been approved for the treatment of melanoma, much more, and Dr. Whitman went through that quite well. I don't have to recapitulate that. So there are data to support surgery for metastatic melanoma in a very highly select group of patients reported before the introduction of active biologic agents. So the question now is, does the application of those effective agents change the role for surgery in metastatic melanoma? Some of you may know what this is. You may have had it as a kid, or you gave it to your kids. It's a thing where you took that stylus and you wrote on the piece of plastic a little note, and then when you're done, you just pulled it up, okay? So I thought of this as, in the age of systemic therapy, or effective systemic therapy, are we going to just pull that piece of plastic up and say there's no indication at all for surgery? And I would say no. And this is how I look at it. Think of the bucket as patients who would derive benefit from an operation for metastatic cancer. And again, we go back to that list I gave you of indications for surgery. Again, small amount of disease, long disease, free interval, et cetera, et cetera. Today, after 2011, we now take out of that bucket those borderline patients that now have a better option than surgery. In addition, patients who have high-risk melanomas who don't have metastatic disease are going to some may be getting adjuvant therapy, which may prevent them from getting metastatic disease. So that makes that bucket smaller. On the other hand, we may be treating patients who have metastatic disease who are not surgical candidates, who have partial responses, or everything is gone except for one spot. So we may be adding in to that bucket as well. So if there's a take-home message, as I see it, is active biologic agents don't change the indication for surgery for metastatic disease, only the patient population. So if we choose our patients correctly, surgery for whatever site should work. The other thing that we should discuss is that when we talk about metastasis, they're not all the same. They're not monolithic. And this is seen clearly in the staging system that we use for melanoma. And melanoma, the M, standing for metastasis, is A, B, C, and D. A is to the skin or subcutaneous tissue or distant lymph nodes, not in the same area, but distant lymph nodes from where the original site was. Eric mentioned briefly about lung metastasis. That has its own category. M1C is metastasis to other organs besides the lung, and D is metastasis to the brain. And these have significant implications, as you'll see here. These are the survival rates for M1 disease based on, let me see if I can use this pointer, based on M1, A, B, and C. And basically, if you look at the 5-year survival rate, you have it from A to B and from B to C. So A does better than B does better than C, and C does, we don't have the data for D here, but that does better as well. The other issue is a serum blood test called LDH, which is sometimes we use that as a marker. For those that have elevated LDH, that has a negative prognostic value. In other words, the patients do worse. And again, essentially by having an elevated LDH, it halves the survival rate compared to those that have normal. So let's just take each one of these sites and discuss indications for surgery and see where it fits in. So as I mentioned, M1A is metastasis to the skin, to the subcutaneous tissues, or to distant lymph nodes. And the options here can include surgical resection, topical therapies or injecting something within the lesion, using electricity, electroporation, and finally limb infusion and perfusion. Now each one of these bullets we can give an hour talk on, but just in general, that's our laundry list or the arrows in the quiver that we have for treatment. Now the M1A site is the most common site for metastasis. And if they are few, surgical excision is probably the safest and the most effective treatment. Now this is one of the plots that Dr. Whitman so nicely described. This is the Kaplan-Meier, the survival curve. And this is data from a trial that Dr. Bickenbach showed, the MSLT-1 trial. And what they did is they followed those patients that had the sentinel lymph node biopsies and looked for patients who had recurrences, had metastasis. And one of that subgroup was the M1A group. And they just compared the outcome. And those that had surgery did significantly better, seen here, compared to those who just had medical treatment. So we know that surgery does play a role. The question is, with all these active agents, is there a role that they play in treatment of metastatic disease? One of the problems giving this talk is that the question's a good question. The problem is we don't have a lot of data. And this is probably the one area that we have some reasonable data to perhaps change how we take care of patients. And this is a trial that was done at MD Anderson, and they took patients who had lymph node metastasis or early stage metastatic disease. They had to have the BRAF mutation, Dr. Whitman explained. They have to have a good life expectancy, and they received two types of inhibitors, the BRAF inhibitor and a MEK inhibitor. They randomized them accordingly, and what they looked at was whether something would happen in terms of recurrences at 12 months. And that's an important point, and I'll explain that why in a second. And this is just how things work. So patients would present with either lymph node metastasis or metastatic disease. Patients underwent a 2-to-1 randomization. You notice these numbers are small, and I'll explain that in a second. In the smaller group, patients underwent surgery for their metastasis, either in the lymph nodes or in the skin or wherever the metastasis was, and they were followed. In the treatment group, patients first received 8 weeks of the inhibitors, both the MEK and the BRAF inhibitor, followed by some x-rays, followed by surgery, and after the surgery received additional therapy with the BRAF and MEK inhibitors. And this has recently been published. So they had, of those 21 patients, they had a median follow-up about 18 months, so it's not a long-term follow-up. But what's really compelling here is that 85% of those patients that received the chemotherapy, we'll call it, or the biologic agents, showed some sort of radiologic response. 2 of them completely gone, 9 of them had a partial response, and this is the famous Whitman waterfall plot that he talked about before, and you can see all of the columns are going down. All those patients underwent resection. 60% of those patients, when they looked at the pathology underneath the microscope, there was no remaining tumor. It all disappeared. Now, the way they designed this trial was that when they found that it was so powerful a result, they had to stop the trial because they didn't think it was ethical to continue the trial as it was written. So that's why the numbers are so small. So the 7 of 14 is quite a small trial as compared to the thousands of patients you saw presented in some of the trials that Dr. Whitman showed. However, MD Anderson has reopened this trial as a single arm to further characterize this trial. So this is actually quite exciting and will be changing the approach to M1A disease. And if you look at the survival curves, again, the primary endpoint was event-free survival. And what that means is any type of recurrence. I mean, and this is quite significant, as you can see. Patients who had distant metastasis also, in given the chemotherapy or the biologic agents beforehand, did significantly better. When they looked at overall survivorship, there was no statistical significance, but a lot of that is because of the small numbers that they had, and based on what these curves look like, if they had more numbers, they would probably show some significance. So this is probably the best data that I have for you in terms of where biologic agents fit in with metastatic disease. Now we go to M1B, which is disease in the lung. And here we don't have very good data after the 2011 explosion of drugs for melanoma. But pulmonary metastases are associated with a better prognosis than any other visceral or organ site. And several institutions have looked at the survival after patients undergoing surgery. And you can see that the median survival is about 18 months and a 5-year survivalship of about 20%. This is just one particular study out of Duke, and it just happens to have a fair number of patients. So over a 35-year time period, they saw 14,000 patients with melanoma. And of those, they followed about 1,700. Those patients had metastasis to the lungs. And of those, 318 were treated surgically. Most of those curatively, some left disease behind. And again, we go back to that, one of my earlier slides saying you really need to remove everything. Okay, again, and I want to emphasize this is before any of the biologic agents. And this is the survival curve shown here. So if you remove everything, you do relatively well. If you don't remove anything at all, that's the standard curves that Dr. Whitman showed. And then someplace in the middle is the incomplete resections. Again, this is a highly select group of patients who are able to undergo resection, and for the most part followed those indications that I talked about. Oligometastatic disease, that they were able to undergo the operation, and for the most part were able to remove everything else. The other thing that this paper looked at are there certain things or certain factors that would predict outcome? And they looked at the histologic type, so the patients who had non-nodular type, those who had smaller number of tumors, less than 2 or less, did better than those who had greater than 2. That disease-free interval that I mentioned as the indications for surgery, the longer that disease-free interval, the better the patients did. Did they have control of all the disease? If they did better. And finally, if you did and you underwent resection, you did better than if you didn't. So highly select group. This is all before the time of biologics, but it is certainly still an indication for surgery. We'll move on to M1C, which is metastasis to other organs other than the lung. And although these can be solitary, for the most part, they are multiple. For the GI tract, we often operate on patients for palliation. In other words, they have a blockage or bleeding or the tumor is perforated. And the most common site is the small intestine. This is a representative study, again, the term retrospective that Dr. Bickenbach mentioned. In other words, from a database, they just looked at the results, not a prospective study. It's 124 patients, about 70 were treated surgically, 55 treated non-surgically. The most common site, again, is small bowel, colon, stomach, and rectum, but it can go to any site at all. And this is representative of most of the retrospective trials that we see for M1C disease. And again, if we select our patients well, this is the survival curve. These are the patients who underwent curative surgery. And if you had palliative surgery or had no surgery at all, those curves were essentially superimposable. So highly select group, but if you're able to remove it all, you can offer a reasonable survivorship. Tumors can also metastasize to the liver. The options, again, are resection. We can do other ablative therapies, either by burning it, either with heat or with microwave. We can embolize or take away the blood supply. And there are some small centers that do perfusion, where they put in high doses of chemotherapy just to the liver. This is just a summary of a variety of studies that looked at surgical resection for melanoma. These are highly, highly select patients, oftentimes from ocular melanoma, less so from skin. But again, you can achieve 20, 25% 5-year survivorships in a highly select group of patients. Again, I stress, all of this is before, we have no data what happens after the biologic agents are in use. I just show this to show the complexity of the isolated perfusion to the liver. It does, for the most part, require an operation. And basically has been given up at this point, I think, for the most part, because of the biologic agents that we have now. We're getting close to the end here. M1D disease is to the brain, and Dr. Whitman showed you that New England Journal of Medicine article that showed the efficacy of dual therapy for brain metastasis. But essentially, if you have a brain metastasis, your choices would include the inhibitors, immunotherapy, as well as radiation. Surgery is used for those patients who are symptomatic at the time, have small numbers of lesions, or show that there's bleeding at the time. But it is a combination of more radiation plus minus the biologic agents. So we'll go back to that question that we asked. When is surgery for metastatic melanoma the most appropriate treatment? So we don't know the answer. So what we often do is we sit a bunch of smart people in a room, sort of thought leaders, and they come up with their recommendations. And this is from the Society of Immunotherapy of Cancer Consensus Statement on Tumor Immunotherapy for the Treatment of Cutaneous Melanoma, version 2.0. Dr. Whitman was actually on this panel. And this is what they recommend for stage 4 disease in 2018. All patients will get full imaging, including an MRI, to make sure there's no disease in the brain, review of the original pathology, serum LDH, and a tumor analysis, mutational analysis, especially with BRAF. Other factors that are included in the treatment should be the patient's performance status, how healthy they are, the burden and tempo of the disease. And that means the amount of tumor, as well as that disease-free interval, that distance between the primary and the metastatic disease, and the presence of CNS or brain metastasis. What's interesting, and this is taken directly off of the paper, panelists acknowledge that the role of surgery is changing. And that is a true, I think, and I would say the surgery is not changing, but perhaps the patient population is changing. First-line surgical resection was a minor opinion of the panel, so there's still some holdouts amongst the surgeons that think it should be done first, but that is changing. And it may be appropriate for a select group of patients, and one example that they used is a solitary lung lesion where complete removal is possible. And then they offered a rather busy algorithm to help us figure out what we should be doing for these patients. And the first line is often clinical trial, which is always the right answer. But the treatment essentially comes down to a very individualized treatment for each patient. So to summarize, and this was a quick, straightforward talk, the indications for surgical resection for metastasis still hold true across the board for any tumor type. And again, I'll go through them one more time. Small volume disease, a long disease-free interval. The resection has to be done with minimal morbidity and offer maximal benefit. Good operative risk. Everything needs to be controlled or controllable, and all disease must be removed safely. And most importantly, no other means of effective treatment. The role of effective biologic agents doesn't change the above criteria, only the patient population that we apply it to. And based on the best data that I can show you at this time, the neoadjuvant therapy prior to surgery is quite compelling and is presently being investigated. Now, most of the talk like this, I think, should be ended in a quote by a surgical oncologist who was a giant about 10 years ago from the New England area, this Dr. Blake Cady. And this is his quote, and we see this quote all the time at our local meetings. And in the world of surgical oncology, biology is the king, selection is the queen, and technical maneuvers are the prince and princess. Occasionally, the prince and princess try to usurp the throne. They almost always fail to overcome the powerful forces of the king and queen. Now, this is, to me, kind of pessimistic. So I look at it differently. And so my addendum to this is, if we identify favorable biology and select our patients carefully, the king and queen will graciously abdicate the throne to the prince and princess. So with that, I thank you for your time, and I think I got you back on time, and I think we're holding the questions till the end. Okay, thank you very much.